Welcome to this show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about cancer of the esophagus. Cancer of the esophagus is a very difficult cancer to diagnose and extremely difficult cancer to cure. According to the American Cancer Society, this year 16,940 folks will develop cancer of the esophagus in this country. And of that number, 15,690 people will die of that cancer, which means it's very difficult to cure anyone from this cancer. Worldwide, 482,300 people will be diagnosed with cancer of the esophagus this year, and of that number, 406,800 folks will die of the cancer of the esophagus. So this tells you how difficult a cancer it is to treat. And of course, the risk factors, as I spoke to last week, of course, are chronic alcoholism, which is alcohol abuse, tobacco smoking, achalasia, Barrett esophagus, something called Plummer-Vinson syndrome, celiac disease, consumption of too much red meat, HPV infection, especially HPV type 1 and 18, line strictures of the esophagus, etc. As I mentioned last week, the symptoms are usually difficulty swallowing, pain in the upper stomach, chest pain, weight loss, anemia. And I spent a great deal of time last week discussing the whole concept of anemia, and I wouldn't bore you with that anymore. Suffice it to say that if one has cancer of the esophagus, the person's best chance of surviving this cancer is for it to be diagnosed very early, either incidentally in the process of having an endoscopy done as a routine thing or for some other reason, and something is found in the esophagus, and or someone just simply pay close enough attention to realize that a patient that is completely totally asymptomatic has happened to have low ferritin. The ferritin is the storage iron, and the storage iron is the first iron that is depleted very slowly when someone is bleeding very chronically from whatever the process is that's causing them to bleed. In this case, it will be someone who has a process in the esophagus that is causing an irritation to the cells, such as esophagitis, etc., that then that's causing the person to be losing blood very slowly. Now, if one understands, as I stated last week, the whole concept of iron kinetics, then one will be able to raise a red flag and determine why the ferritin is dropping. The normal ferritin in a man is 322. The normal ferritin in a woman is 290. So if the ferritin in a man, let's say, is 100, well, you can't just file that away because that is abnormal. Since the normal is 320 and it is 100, you can't file it away just because the hematocrit, which is really an indication of the red cell count, is normal. That just doesn't make any sense, because if you investigate that, you're forced to investigate that by doing a GI evaluation, during which you will definitely 100% of the time find what the cause of the low ferritin is. Now, if the person is urinating blood, he or she will see it. If the person is vomiting blood, he or she will see it. If the person is coughing up blood, he or she will see it as well. However, if you're bleeding very slowly and the blood is mixed with the stool as it comes out when you have bowel movement, it takes a minimum of 25 cc's of blood mixed in with the stool when we test the stool for blood via, let's say, doing a hemocold test for it to become positive. And not to make matters even worse, the bleeding almost always is intermittent. You don't bleed regularly, you bleed intermittently. So those are very difficult things, but they're very important thing for someone who's practicing clinical medicine to understand. If you don't understand that, then by the time you pick up the fact that your patient has cancer of the esophagus, it would have been 2-3 years later. By the time 2 or 3 years later, the patient, because you have to lose the entire storage iron first, the entire storage iron, and more than a third of the circulating iron before anemia shows up. Let me repeat that. You have to deplete the entire storage iron in a man, which is 1.5 gram, and a woman, which is 1 gram. 1 gram is in a woman, that's 4 units of blood. 1.5 gram in a man, that's 6 units of blood. So we'd have to lose in a woman 4 units of blood and a man 6 units of blood. A unit of blood is the bag of blood that when you go to donate blood in the bank, in the blood bank, that they take from you. This big bag of blood, that is a whole lot of blood. And, and each unit of blood has 250 milligrams of iron. So it's not difficult at all to be able to calculate what has happened. If 2 units of blood represent 250 milligrams of iron, and the person comes into your office with a ferritin, let's say, of 20 or 10, right away you know the person not only has lost the 6 units of blood in a man or 4 units of blood in a woman. If anemia sets in as well, he or she would already not only lost that amount of blood that was in the storage iron, but it also lost almost a third of blood of the iron that's in the circulation. That's when anemia sets in. If you're waiting for anemia to set in to be able to diagnose GI malignancy of any types, you are way behind, way behind. Now, somebody can be bleeding acutely. Yeah, there are many conditions of the esophagus, for that matter. You could have esophageal varices for a multitude of reasons, not the least of which is cirrhosis of the liver. Then the person can vomit a bucket of blood, literally. That's not what I'm talking about. That's easy. The eye can see that the person is vomiting blood. That's acute anemia. That's normochromic normocytic anemia. That's an anemia. That's a separate issue. That's not that difficult to diagnose because you could see it. However, the most important thing when you're practicing bedtime medicine is to be able to know these things. And if you don't know these things, then he or she ought to send the patient to a gastroenterologist or to a hematologist, people who are familiar with the kind of stuff that I'm talking about. So now, let's then go about how do we evaluate a patient who comes to you with this complaint. Well, first thing you would do, as a routine process, you will of course examine the patient. You will test the stool for blood right in the office. Then you will order a complete blood count. You will order a complete metabolic chemical profile. Then of course you will proceed to also order a serum ferritin at the same time. And then once you do those things, then if this test come back abnormal, even if they're not come back abnormal based on the patient's symptom, then the patient will be sent to a gastroenterologist. But even before you get there, you could do a CAT scan. You could also go ahead and do an esophagram, which is where they swallow some contrast material, and the radiologist take a picture. And of course, you could also at the same time do the CEA, because the CEA is a marker for GI malignancies. But the most important of all that is referring the patient to a gastroenterologist who will then do an endoscopy. Years ago when I began to practice, those things were not being done routinely. Now they're routinely all over the place. So, and the GI doctor then will scope the patient, evaluate the esophagus, evaluate the stomach to see. And nowadays we have physicians who are capable of evaluating the small bowel at the same time in the same setting. Not all of them can do that, but you have those that have a special expertise in that. They can actually do that at the same sitting. So now that's the upper GI evaluation from the throat all the way down to the small bowel. Okay. Now, if nothing is found, then of course, at the same time, the patient is already prepped. They can do a colonoscopy, and then you will evaluate the entire GI tract. You should get under where is the blood loss is coming from in a man. If it's a woman, things get much more complicated than that. Much more complicated. It gets much more complicated because women menstruate. And they started menstruating since they was 9, 10, 11 years old. And each menstrual period, they lose a minimum of 50 cc's of blood. But one can calculate that, as we could calculate, go back and calculate that. And then if the woman has her children, then you could calculate how much blood she has lost during each pregnancy that carried to term. Because for each pregnancy that a woman carries to term, she by necessity must lose 750 milligrams of iron. Let me repeat that. Each pregnancy that a woman carries to term, by necessity, she loses 750 milligrams of iron. And that is the equivalent of 3 units of blood. We say, well, how that happened? Happened because the fetus must survive. The fetus must grow. In the process of fetal growth, the fetus uses that iron, takes that iron away from the mother. That's right. Unfortunately, nowadays, even in this country where medicine is so highly developed, there are those who are in control of taking care of women that are pregnant are not up to date enough in how much iron a woman needs in order to replace that 750 that I just told you. In addition to that, all menstruating women are iron deficient. Let me repeat that. You can't be a menstruating female, don't be iron deficient. You may not be anemic, but you are iron deficient. Okay, in particular for those who have given birth. And then that, to make matters worse, for women who also breastfeeding, because when you breastfeeding, you're losing iron this way, that way as well. So that makes the situation much more complicated in a woman patient who has cancer of the esophagus. But there are ways of raising the red flag. Those are complicated issues. I'm not going to sit here and detail all of them to you. This big book that I wrote, The Art and Practice of Modern Clinical Medicine, believe it or not, there's a huge chapter on OBGYN. Even though I'm not an OBGYN physician, but I'm a teacher. I teach clinical medicine, and OBGYN is part of clinical medicine. So there's a huge chapter on OBGYN where I take the time and I details all these things for you, all the nuances, all the gross things that everybody else know, and all those things that very few people know, all described there to you. Because my purpose for writing this book is not to sell book. My purpose is to make an academic contribution, in particular for students and interns and residents. Every year, when the students come to my office, each one of them wind up with a copy of this book. They treasure it, because there's stuff that in this book, even though it is very advanced, but the 4 years passes pretty fast. The 4 years passes pretty fast. Once they hit into their internship, they're going to need some of this knowledge in order to manage patients. Once the June 30th come, believe me, all these folks have to start that internship in June 30th somewhere, wherever they were accepted. From day one, from the first patient they put their hands on as an intern, some of this stuff that they're going to need to manage that patient, to diagnose that patient, and how to better treat this patient are all found in this book. I have students, I tell them, when you come into my office, first of all, I shouldn't tell you that, but I'll tell you anyway. There's a lottery. You just don't come to my office as a student. I have nothing to do with it, but I'm told by the student they have to go through a lottery, a very, very well-done lottery for them to get a chance to come to be taught medicine by me. And they take it very seriously. And I didn't even know that. They revealed that to me. So it's not that easy to come to be taught by me. So I'm not the one choosing them. And then I tell all of them when they call me, give me a week or so before they show up at my door, I tell them to get their lab coat, to get their stethoscope, and to get their little black book. That's right, and pen. And I told them, see this black book here? every single thing that is of value that I want you to write it down, because you're going to need that black book. You're going to need that black book. A colleague of mine who we taught as a team at Montefiore years back, and then I saw her in the hospital, one of the hospitals. She had this big black book in her bag. I said, now wait a minute. You're a married woman. What are you doing with the black book? She says, Val, I can't come to the hospital without this black book, because whenever something hard I have to diagnose, I looked at black book and I remember what you said when you and I were teaching together. I said, you got to be kidding me. She said, no, never leave my house without this black book, this big black book. So I tell the student the same thing. Bring your black book and hold on to it. Hold on to it, because you're going to need it when June 30th come, that you have to become an intern. So, as I said last week, I frankly couldn't care less what people think in terms of accepting me, because I'm not in the business of looking for acceptance. But I dare you not to include me when it comes to clinical medicine and clinical medicine issues in the 21st century. I dare you. I don't care who you are, where you are, what you think you may be. But in clinical medicine, you better include me. You have no choice. And that is God that did that, not me. Okay, so that being said, now that you've got your endoscopy, a biopsy is taken of this mass that they see in your patient's esophagus, and this is then gets sent to the pathologist. Gets sent to the pathologist. Once it is evaluated by the pathologist, then it's come back cancerous. Oh my God, what a bad news. I know. I've had cancer 3 separate times. Of all the bad news you could give to anyone that is sick in a hospital or in an outpatient setting, nothing is worse than when you're told you have cancer. And it happened to me 3 separate times with 3 separate type of cancer. So, and what I'm talking about, I'm not just somebody who treat patients who have cancer or who teach intern resident what cancer is like and how to best evaluate it and treat it. I'm a cancer survivor ×3, okay? So, now that you got the result back, where do you go from here? Okay, well, here you go. Now you're going to have to do what's called a clinical staging. Clinical staging, the best way to do it is to do a PET scan. You could do a CAT scan, you could do an MRI, you could do all this other stuff. It's what the insurance companies are willing to pay for, whatever. But you could bypass all that by doing the PET scan. What is the PET scan? As I said before in previous shows, the PET scan is a test that is available in this country and elsewhere around the world, quite expensive, whereby a molecule of glucose is infused after it is mixed with a tracer, a nuclear tracer. It is infused into a vein, and the patient is rest very quietly, and then the cancer cells, wherever they are, is going to grab onto that glucose, because cancer cells love glucose. They can't grow without glucose. So knowing that to be the fact, the powers to be, years ago, very intelligently come up with this idea so that to do a PET scan. Believe it or not, the powers to be, the insurance companies, except for Medicare or Medicaid or the other Medicaid-like plans, will not pay for a PET scan inside a hospital. Don't ask me why. And this stuff is expensive. Hospital has to pay for the nuclear tracer. They have to order it ahead of time. They won't pay. And it is a battle to get these folks to pay for something that is so important and so crucial as an outpatient. And I deal with it every day. My colleagues deal with it every day. It's a fight. It's an all-out war. You have no idea. You can just imagine the amount of time that I spent every day fighting with insurance companies to get them to approve things to pay for different tests that patients need for different medications that patients need. It's an all-out war. They do it for one reason and one reason only: to save money. To save money. What they're going to do with that money, nobody knows. Some of them are making millions of dollars. People who, if they saw clinical medicine, they wouldn't recognize it. They wouldn't recognize it. Even in bright daylight, they see clinical medicine, they wouldn't recognize it. This is to say, this is how bad they know how to practice it. They know that. That's the reason that many of them wind up becoming involved in this CEOs, HMOs, and PPOs, or whatever you call it. They have to make a living. I don't begrudge them. They have to survive. But they should have at least some humanity in them when you're discussing. Not all of them are terrible. Some of them are more reasonable than others. And sometimes you wind up with a situation where you're speaking to someone who's not a physician. They're nurses. They're very nice, very bright people. But clinical medicine is an art, as this book says. It is not something, you can't just know a little something about it and think you understand it. Okay? It's awful stuff. But you have to be very polite, very gentlemanlike to talk to them. You have to be. These are women, most of them. You always thought you must be always gentleman, polite with ladies. It's not their fault. They have to make a job. They have to make a living. But they don't know enough to be able to completely understand what physicians are talking about. But that's the reality. To get to talk doctor to doctor is a very difficult process. And sometimes, frankly, you're better off dealing with the nurses than dealing with the doctors. Some of these doctors are absolutely ridiculously impossible to deal with. Not all of them. They're just absurd. But that's what you have to deal with. And your patient is sick. The patient needs the test. You can't go, but it's a constant fighting, constant arguing, whatever. So you can't do a PET scan unless you've done a CAT scan first. But you can do a CAT scan for the entire body. But the cancer could have metastasized anywhere in the body. But the PET scan will pick it up. Because wherever there's cancer cells that grow, it will grab onto that sugar that is tagged with a nuclear substance, and then it will light up. When it is scanned, it will pick it up. Nowhere, from the head to the toe. Well, no, you got to do the CAT scan first. You got to do the CAT scan of the abdomen. You have the CAT scan of the chest. You have the CAT scan of the. You have to do all that. If you didn't do that first, well, your chances of getting your PET scan approved is nil. Well, fine. So you do the CAT scan. You do all this, you do the chest X-ray, you do all that stuff, you do the CE, you do all that. That's a clinical staging that tells you how advanced the cancer really is. That's what that's all about. You have to do that. Then once you do that, then that allows you to then now proceed to offer the patient some form of treatment. And the treatment that's available for cancer of the esophagus include surgical resection, radiation therapy, or chemotherapy, or combination of chemotherapy plus radiation therapy. You have different combinations like 5-FU plus cisplatin, epiridobacter, oxaliplatin. It's different combination of medication. It doesn't pay for me to be explaining all this stuff to you. Suffice it to say, the 5-year survival is very, very, very bad. Okay, the 5-year survival for cancer is 11% in blacks and 18% in white. Very bad cancer. As I told you, the statistics, when I just began talking about it, you got 16,940 people will develop it this year. 15,690 folks will die from it. It's a horrible cancer to have. It is horrible cancer. And of course, by the time you get to the point where you have to give this treatment, the cancer is almost always already advanced. It is almost always, and it's more common, by the way, in black folks than it is in white folks in this country. 50% more common in blacks because of the diet, because of the smoking or tobacco smoking, abuse of alcohol, lifestyle in general, poverty, and it is fair to say that black folks in this country and across the world are poorer than white folks. And the poorer you are, the less likely you have to have the necessary amount of money to pay physician to evaluate you, to have the proper insurance, and so on and so forth. And diet is a major part of it. The food that has the most grease in it, all this spice and all this other stuff, all these things are very irritating to the lining of the esophagus, rendering it more likely to become, for the cell to become dysplastic. When you drink a lot of alcohol in combination with cigarette or other type of tobacco smoking, those poisons that are in the cigarette and the irritation from the alcohol, all those things render the esophagus all irritated, swollen, you develop gastritis. Those are the beginning processes that can ultimately lead to cancer of the esophagus. It's a bad cancer. No one should wish cancer on anyone, but this one is an awful one. Worldwide, 482,300 folks are scheduled to develop cancer of the esophagus this year. And of that number, 406,800 people are going to die. The percentage of survival is very, very small. So the best thing to do is lifestyle changes. Give up the cigarette and the tobacco smoking. Don't abuse alcohol. Modify your diet, and hopefully you stand a chance of not getting cancer of the esophagus. Listen, I'm stopping here. Until I see you again, this is Dr. Alcena saying so long and bye-bye.